Thanks for the opportunity to make a short presentation. And my goal in this presentation is to talk a little bit about standardization of dosing for acute pain and kind of where some of that comes from. And also to use dentistry as an example of a specialty profession, prescribers, that has had some dramatic impact on the number of opioids being prescribed, but also perhaps to point to some ambiguities in terms of guidelines that we might be considering as we look at standardized interventions or the attempt to standardize interventions for acute pain, such as procedural or traumatic pain. And so one of the reasons that I chose dentistry is that it is a model of an acute procedural pain. And one of the things that I mean by that is that when you look at the analgesic equivalence tables that we're all familiar with, that sort of illustrate the difference between the amount of oxycodone that it would take to be approximately equal analgesic to morphine, similarly hydrocodone and so on, that these are largely developed through comparative studies that have looked at procedural pain, like extractions of the third molars, otherwise known as the wisdom teeth, or bunionectomies. So these are rather painful procedures that have an expectation of somewhat standardized extent of pain and duration of pain. And when we look at our equivalence tables, this is where those have come from. And so one of the other things to consider then is that since third molars are frequently pulled in older adolescents, or 16-year-olds, 18-year-olds, and so on, my 19-year-old is getting his out in June, so I'm kind of looking forward to seeing exactly how long this is going to be a problem for him. This is one of the ways in which opioids are introduced to adolescents in a prescribed fashion. One of the ways in which opioids that might not otherwise be in the house get in the house. And I found it interesting that about 20 years ago, dentists were the leading prescribers of immediate release opioids. They are still one of the specialties that prescribes a lot of immediate release opioids, but I'm really encouraged by the fact that they've reduced the number of opioids that have been prescribed by dentists dramatically in that time. So going from about 15% of all the immediate release opioids to about 6.4%. Now understand that this is the number of tablets being prescribed. They are still they are still one of the predominant prescribers of immediate release opioids, and understandably so. But we'll get back to some other options for that as well. And so, again, this is something that we kind of expect to be a part of almost going into adulthood, is that they're going to have their wisdom teeth pulled. And what kind of expectations do we have for the type of medication that's going to be prescribed, and especially the numbers. And I mentioned the numbers because if we look at some of the data that has been pulled together by surveys of adolescents and young people, this was a study that was looking at people who were not considered to be addicted and dependent, but had used prescription drugs recreationally. And if you look at this pie graph, basically everything but the little slivers at the very top, you can argue were derived from excessive amounts of opioids that were available. So if you start from I guess at about 12 o'clock, you've got a medium blue wedge. And then moving clockwise, you've got a red wedge, green, and then purple. So these are owned prescriptions, or given free by their friends, or given free by relatives, or they bought it, or they took from relatives, which is not a very large fraction, or they took from friends. You see that the doctor shopping, the internet, and other are really just slivers, just not even a few seconds of that clock, which is to say that the young people who were using prescription medications recreationally, illicitly, they somehow had these prescription medications available to them. Somebody had them to be sold, someone had them to be given to them, or they had them themselves from their own household. And so anything that we can do to decrease the number of doses that are left over is going to decrease the likelihood that this diversion and misuse can occur. And so I wanted to kind of take a look at some of the other things that we might be considering as we look at the safety of these opioids at home, particularly when we're looking at other risk factors, although my bullet here is more general in that we're not expecting a lot of young people to have sleep apnea, other conditions, but they might be on benzodiazepines or other interacting medications, something that we would need to be considering. Safer opioids at home, of course, my focus is going to be limiting the number of doses prescribed and then taking it as exactly as prescribed and getting rid of expired or leftover medication, and providing information on drug return locations might be one of the other didactics that we have down the road, kind of updating on where and how to return medications or get them out of the supply chain. But it is a problem, and one of the big concerns here is that if these are not misused, but well, if they are misused in the sense of accidental use, that they also provide a hazard. We're thinking, I think, in our mindset about it being the opportunity for recreational use and perhaps dependency and use disorder. But just a reminder that if it's accidentally ingested by younger children or pets, that these opioids that are still present left over are going to be another substantial risk factor. When you look at a survey that was reported out about 2 years ago, they looked at the number of opioids that were left over after extraction. And these next two slides, I think, are important or kind of interesting to look at, because it raises the question, how many doses of an opioid, and most of these, frankly, are going to be something like, hydrocodone and acetaminophen combinations. And this is not a large study. We're looking at the number of patients that had leftover medication, and you'll see that these have column titles of control and intervention. And there's really not much of a difference between the control and the intervention groups. They were basically told about disposal opportunities, but they really didn't focus on risk so much as you might expect, despite the fact that they were talking about disposal opportunities. And if you look at the differences between these groups, there are not a whole lot of differences. The percentage of females, you remember the age, number of teeth extracted, and so on. And the number of individuals that filled the prescription, about the same. So, and if you look at the demographics, these two groups are looking fairly similar. I think more interesting is the group with and without the dry socket. The dry socket, you would expect to have more pain. And what is interesting here is the mean opioid analgesic pills prescribed versus consumed, and the percentages of individuals with any of these analgesics remaining after day 21, when we would expect most of the pain of the extraction to have dissipated. And you can see that in both cases, both those that had a more severe pain, perhaps with the dry socket, and certainly those without the dry socket, the majority of them had medications left over. And if you look at the number of actual pills prescribed, it's not like everybody got 1,870 tablets, but if you divide the 1,870 pills by 67, for example, you get a number approximating about 28. So that's really not new information, but what's really interesting is that about half of these were left over. 54% of those 1,870 tablets were left over at the end of 21 days. Now, one of the things that is also interesting to take a look at is if we just focus on the without dry socket column, that we have an average of 13 tablets were consumed and per individual. And the standard deviation was huge here in that it was a standard deviation of 10. So some of these patients took virtually all their medication, and some of them just took 1 or 2 tablets. And I think that it's perhaps easy to think that the dentists are being too liberal in their use of opioids. But I wanted to call out this other study that looked at hundreds of thousands of Medicaid claims and looked at the likelihood that somebody would get an immediate release opioid for a dental pain. And the dental pains are buried in this, and I'm not going to go into the details about these different types of dental pain that they had. But what surprised me is that the dentists were far less likely to prescribe a lot of opioids than the other prescribers listed here. So we're looking at the odds ratio that patients are going to be getting opioids. And the ED physicians were about almost 5 times more likely to prescribe an opioid than a dentist would for the same coding. And similarly for the medical specialist, the physician or nurse practitioner. So the dentists, despite the fact that we might think that they're being a little bit liberal from the previous slide, are actually more conservative in their opioid prescribing. We'll see that in some of the newer recommendations in a couple of slides. The other thing that I thought was interesting was the effect of ethnicity in this. I have seen other data that suggest that for broken bones, for example, African Americans are less likely to receive an opioid than other races. And what was interesting in the study of dental pain is that when they compared it to Hispanics, that African Americans and non-Hispanic whites were over 3 times more likely to get an opioid. So it's more likely that the Hispanics are going to be, in a sense, less likely to get opioids. But what was also interesting here is that there didn't seem to be a significant racial difference in terms of the likelihood of an opioid being prescribed to an African American versus non-Hispanic white for dental pain. That being said, there does seem to be a racial disparity among this Medicaid data, and it would be interesting to see why that might have happened. And so one of the things that I wanted to sort of bring up in the recent study a recent paper that summarized multiple studies, was published just last month, I think, in the Journal of the American Dental Association, is that the ADA has come out with some guidelines that are very similar to what the CMS is recommending, and that is that we should be limiting the prescriptions for immediate release opioids for extractions to about a 7-day supply, and that, of course, as prescribers prescribing those opioids, they are obliged to look at the prescription monitoring database. And the other thing that they pointed out was that in terms of the likelihood of a control of the pain, that the combination of ibuprofen at 400 milligrams, acetaminophen at 1,000, was more effective than the combination of oxycodone and acetaminophen, and presumably the hydrocodone, although that wasn't as dramatic a difference. Actually, it wasn't listed in the same table. So what that is saying is that there is really no strong reason to be prescribing the acetaminophen hydrocodone or the acetaminophen oxycodone combination instead of the ibuprofen acetaminophen for these simple dental extractions, the wisdom teeth extractions, unless there's some other contraindication for the use of the ibuprofen acetaminophen, which argues that we should be able to use opioid-sparing interventions for these standardized treatments, at least of the wisdom teeth. And I wanted to then close with this last slide. So the CMS and the Dental Association are recommending a 7-day supply. What is a 7-day supply? If you presume that 1 to 2 acetaminophen hydrocodone tablets every 4 to 6 hours might be maximally 84 tablets. That is 2 tablets 6 times a day for 7 days, 84 tablets. But we saw from the previous study, from Megan's study, that the average use was more like 13 tablets. And so 84 tablets would seem to be excessive if we're talking about a conservative 7-day supply. And so I think one of the things that prescribers might learn from physicians that are taking care of trauma patients, from dentists that are taking care of extraction patients, and orthopods and podiatrists that are taking care of bunionectomies, is to try to better understand how many tablets an individual was taking in their follow-up of the patient. And this kind of follow-up information, I think, is going to be really, really helpful in identifying the appropriate number of tablets. One of the things that's been suggested is perhaps a small number to go out with, maybe 3 or 4 tablets. And maybe Melissa can comment on that and the guidance that the outpatient pharmacies are getting to deal with a paired sequential prescription, so that the first prescription gets filled for maybe 4 to 6 tablets, and then a second prescription is available if that is inadequate, but that it can't be filled for a day or two, but it allows for a limitation of how many doses actually go out the door up front that may not end up being used. So I'm going to stop there and invite comments both from pharmacists that are dealing with this in terms of the dispensing side of things, but also your experiences with how much of the medications that you think that patients are going to be needing have actually been used. Can you pass that?
No, a question I'd have actually where I feel like, and I guess this would more apply to chronic painful things, but I have pharmacy expertise here, and you're the people to ask this question because I tend to turf it to you during clinic, is appropriate storage. And so I speak with patients about keeping them in a locked location, but then I generally tell them to ask the pharmacist about it when they go there, and I wonder if there would be ways for me to improve on that, like is there payer coverage for that resource in some cases, and that sort of thing, or how I might advise folks better.
Yeah, I'm going to have to defer to Melissa about that in terms of what the guidance is or the reimbursement is for safes. And quite honestly, before I ask for that comment, I'll observe that if you are dealing with a key operated safe, then somebody has to have that key, especially if it is someone that's a caregiver that's working on the behalf of the person that's going to be taking the medication. So if there is someone that is getting the medication from the safe that's not the patient, there's also that question about whether that is a break in the chain, if you will. Biometric safes with fingerprint readings and so on are going to be more conservative, but a little bit more expensive too, basically gun safes. Mm-hmm. But Melissa, let me put it to you. Do you have any guidance or advice about what the UW Health pharmacies are advising people in terms of safes and the kinds of safes and whether or not they're covered by insurance?
Yeah, so they are not covered by insurance, and that makes it a big struggle because some of these safes, especially like you said, the biometric safe, can be fairly costly. And really, to be honest, on an outpatient level, because we can't offer coverage, we do tell them to put the medication in a safe place. And probably our biggest counseling is ensuring they know about proper disposal. We had an initiative we were doing with United Way about giving out actual disposal bags that had stickers with addresses on it of where they could dispose of medication, and we were handing those out for free. We've also started piloting some of the charcoal bags. I don't know if you guys are familiar with that, but an actual bag you can open up, put the medication, add water, and it makes the drug, you can't pull any active medication out of it, and it makes it null and void, and you can actually then dispose of it in the garbage. The unfortunate aspect to that is there is a cost associated with that. So we piloted it in our oncology clinics, and they've been handing them out and using some funding to help cover that cost for the chemo type patients on opioids. But that would be a great expansion method as well. But unfortunately, as for safe storage, we don't have much we recommend outside of safe storage.
Now, my understanding is that the American Family Children's Hospital pharmacy has some lock boxes available. Is that still the case?
I think they do, but I haven't been over there in a while, and that's not one of the pharmacies I oversee.
Okay, thank you.
In some parts of the state under HOPE grants, we do cover safes for our clients that are under the HOPE grant. And those are, let me see, I think they're a combination of both putting in numbers or the key. The difficulty we've had is that if people don't attach them to something, sometimes we've had the whole safe stolen.
Right.
But it's safer with children around, much safer.
Gotcha. One of the things that's a little bit difficult to do is to find out really what the use is for the prescribed medications. We had a study that was done in a Dane County medication drop that showed pretty much the same results as what I showed you on this other slide, that about 50% of the prescribed number of opioids were returned in this medication drop day. And it would be nice to be able to have some sort of a retrospective assessment of exactly how many tablets people have used for the indicated purpose, as opposed to kind of kept it in the cabinet for, you know, a sprain or some other pain that they felt that they could use this stash for. And I don't know that I've seen a systematic assessment of where, of how many of these doses have actually been used.
I've seen some in trauma literature use in the post-operative period and how many opioids are getting used for the reason that they were prescribed for, and it was pretty much in the ballpark of what you were saying.
Well.
And it was something like, I'm probably flipping these statistics. It was either 66% of opioids were unused or 66% of patients had opioids left over. It was one of the 66% was one of those two things.
Very similar.
So yeah.
So one of the things that I mentioned, and that we mentioned when we did the medical examining board opioid training, was to suggest double scripts. And so, Melissa, can you comment on the economic penalties that the patient might experience if they got two prescriptions, a small one to begin with, and then another one to follow up on that maybe expires in 7 days, that if they do need a few more than the prescriber initially thought, they can get it? Is there any penalty that they experience for that?
There is so there would be an additional copay with that. Whether it would be double the copay just depends on the insurance. So they might have that set generic copay. Because a lot of the immediate release products are so inexpensive, a lot of times we'll see that copay be even less than their standard generic copay, but there would be that additional impact. But a lot of times we've seen some strategies where people are using that smaller quantity and then allowing people to come back. And a lot of times people aren't needing that second fill. And again, then there's an additional cost to it. So if they really don't need it, then they might not obtain it and keep it for later.
Right. Yeah, kind of similar to like a delayed antibiotic prescription.
Yeah,
makes sense.
It's not a huge hurdle to jump over,
yeah,
but it's another hassle.
Yeah.
That if they don't need it, perhaps they won't do it. Right.
The other thing that we have done in some of the community work we've done is to really make parents aware of the risk of opioid exposure for their children and adolescents. Really working to inform parents to have them be very critical consumers of that, because we had the data. FHC has dental centers, so we have the data on medications prescribed, like for wisdom teeth removal, and the fact, and we know also as parents in some cases that the ibuprofen acetaminophen combination works well. So we really encourage parents to start to think about the risk with those opioids, and to really question when they're being prescribed how many are really needed, and know that they have the option of saying, I don't want the whole prescription as well. Yeah. So that has been a fairly effective.
Kind of makes me wonder at what threshold in terms of number of tablets we should be thinking about giving naloxone if there's a toddler in the home. Should it be any opioid?
We're actually, the opioid task force that the UW Health has put together is grappling with that. Yeah. Because an exposure to an infant would be lethal at a much lower dose than the one that we're typically thinking about with the CDC's suggestion of 50 to 90 milligrams a day as being a dangerous dose. But if you've got children in the house, it's going to be much less. So where is that threshold that we should be prescribing the naloxone? I don't know that that's been clearly described. And maybe it shouldn't be protocolized.
No.
Maybe it's just a judgment call.
Would there be payer barriers to, pretty liberal practice along those lines, Melissa? Like if a parent receives 20 oxycodone tablets, but they have an 18-month-old at home, would a naloxone prescription get covered?
So the good news is with naloxone dispensing, there is not those different qualifications with it. So if we get a prescription, it will be, well, I shouldn't say it will be covered. A lot of third parties are covering. We're still hitting the struggle where there are a few insurers who won't prescribe the commercially available Narcan, so we still have to do the naloxone kits.
Oh, really?
Yep, there's still a few out there. But yeah, we would be able to dispense. I will tell you guys that the commercially available Narcan, of course, is a brand name product. And so we've had an opioid initiative going on in our UW pharmacies and have really increased our naloxone dispensing. And I have changed our cost across UW to be the actual cost it is for us to obtain the drug with zero markup. And it's still cost prohibitive for patients, even with their copays. Mm. So we do run into that, and I don't know. So if you have a prescription for 20 tablets, of course you want them to be safe and educate them, especially if they have a young one in the house, but there may be some cost barriers to that.
And we had taken the approach, Dr. Larson is the Director of Controlled Substances for Marshall Clinic Health System. So he has done, a group of us, done much of the education around CDC recommendations and all those sorts of things. And as a best practice, we have actually been suggesting that if opioids are prescribed, naloxone is as well. Again, to raise that awareness of what the risk is with these medications.
So what I'm hearing as well is that even if they choose, perhaps because of the copay and the lack of insurance coverage for any individual, just the fact that they are being prescribed the naloxone and the explanation of why might reinforce the danger of the other opioid. Yeah.
Yes, that combined with at various times there's, we make sure people know where ARCW is doing the free distributions along with the education. Right. So really making sure people are aware of that. But we view any dose of naloxone that gets out in the community as one more safeguard against an overdose by someone.
Yeah. Good point.
Well, great discussion. We're well past our hour.
Actually, this is Doug Engelbert. I just wanted to make folks aware. I know, Dr. Hutson, you talked about doing the double prescriptions. Under the CARA Act, the DEA is supposed to be writing new rules around partial dispensing of controlled substances on Schedule IIs outside of long-term care and end of life. And it's my understanding, as long as the state law doesn't prohibit it, that you can do partial dispensing. So you don't have to do 2 prescriptions. You could do partial dispensing because our laws do not prohibit it. Perspective, and we're waiting for basically the DEA to write laws around that. So just so you're aware of that.
So what you're saying is that the prescribers can, at this point, ask for it partial without the patient being terminal?
Correct. That's some of the interpretations that are out there. That's what we've been hearing.
Interesting. Because I didn't realize that you could read the law that way at this point.
That's what the DEA has commented back. And our state law doesn't prohibit it. It just basically says if you have a Schedule IIs, you can do it for long-term care and you can do it for something else, but it doesn't say you can't do it for anybody else.
I love that.
So,
okay. We'll take advantage of it then. So do you think that there is an advantage in doing it that way? Or is it, do you think that the double prescription might be a little bit easier for the physician or the prescriber? I'm wondering if the patient might say, well, why am I just having to be able to get 2 instead of 10? What do you think?
Well, with the 2 prescription piece, you do have to get physicians to do that. On the partial dispensing, it can happen at the pharmacy level. I think the barrier for the 2 copay issues still becomes a concern. The pharmacy may be incurring costs on the partial dispensing where because they can't do the second copay. So there's some issues that are still existing with the partial dispensing, but it potentially is an option. It could potentially help for people who are having diversion concerns where they have large amounts in their home, and maybe they just want to have a smaller supply and they're willing to come into the pharmacy more frequently. So there's pluses and minuses either way, I guess.
That would be really helpful where you thought that there was diversion going on in the house, but my understanding is that the partial dispensing would be a burden on the pharmacy because they would not be able to ask for a copay every time that they got another partial dispensing of the original total amount.
Correct.
It's good to know. Thank you.